como tal es una condición que se describió hace no muchos años, inicialmente con una descripción original de 3 niñas, que ustedes pueden ver ahí en pantalla, con ciertos aspectos comunes, en cuanto a su patrón de desarrollo, con aspectos comunes en cuanto a la presentación de epilepsia, pero como ustedes pueden ver, ninguna de estas chiquitas tenía ningún rasgo específico que llamara la atención de decir, bueno, esto igual a esto. Entonces, digamos que en medida del progreso de la ciencia y del diagnóstico genético, pues se da el conocimiento de esos aspectos como desarrollo y epilepsia y la curiosidad de hallar el por qué, cuál es el fondo de algunos de esos cambios aún sin rasgos obvios genéticos. Y pues hemos tenido el avance en cuanto a diagnóstico genético en el que se descubrió este gen.
Hi, good morning. My name is Deborah Requesens. I am the director of the Orphan Disease Center at the University of Pennsylvania. But today you have me here with my hat as the co-founder of the Hispanic Society for Rare Diseases, Sociedad Hispana de Enfermedades Raras. So before we start, we wanted to show this video. And for those of you who don't speak Spanish, can you raise your hand if you felt like you understood what this doctor was saying? Yes, it's just we want to start this conversation by saying that translating with subtitles partially is just not enough, right? You're trying to catch what he was saying, you're trying to look at the images, you're trying to look at the words that are going very fast, and this is just to highlight the challenges that the Hispanic community have in the rare disease space. We are more than just a language that needs to be translated, and today I'm super excited to have this panel with me who is going to talk to us about our challenges, but also about the opportunities that many researchers and foundations have by working with our community. So thank you so much for being here. Maybe we take this opportunity to introduce ourselves. Beatriz, you want to start?
Sure, I'm happy to start. Beatriz Mallory, also known as B. I'm going to start with a small disclaimer in that as a person living with a thyroid eye disease, a rare thyroid eye disease, I'm going to squint a lot because the lighting is very much affecting my ability to work my eyes. So I just wanted to, I didn't know until I got up here I'd be contending with that, so I just want to let you know that's why I'm blinking a lot, not because I'm going to cry. So I am, excuse me, I have just founded an organization called HERD Kids. That's Health Equity for Children of Rare Diseases. And our purpose is to connect low-income children, primarily Black, Hispanic, Native American, and rural white communities, helping those children by connecting their families to the kind of organizations that are represented in the room, foundations, research institutions, and also with each other, because many of them, particularly those who are recent immigrant or not English dominant, very often feel even more isolated than other families with rare diseases. My own background, I, for many, 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 many years, have founded and run advertising agencies and marketing strategy companies focused on, multicultural markets. So I have many years in marketing, advertising, and communications. And in the last 20 years, that focus has been primarily in healthcare and very recently in pediatric rare disease. And so it's been a whole new world to really start working with these families and understand how basic their needs are. And with that, I will end my introduction and look forward to the honor of sitting here with these other wonderful people.
Okay, so my name is Vicky Arteaga. It's such an honor for me to be here with this panel, with everyone here in the room. This is my third year at the Health Equity Summit, and I'm very happy to this opportunity to finally have a panel that we are talking about our needs. I am a Latin American director for SINGAP Research Fund. My daughter was diagnosed with SINGAP1 5 years ago. She was the first patient in Colombia. She was around 200 patients around the world. Now we are talking about 1,235 around the world and only 36 patients in Latin America. So this is important because the numbers are still low, and we will talk about that later. But I'm also honored to be a co-founder with Debbie on the Hispanic Society for Rare Diseases, Sociedad Hispana de Enfermedades Raras, and we recently launched our podcast más que raras in Spanish, which is also a wonderful, achievement. So thank you so much.
Hello again, Mario Estevez. I'm here with the Racial Equity Institute. Our organization does trainings really kind of singularly focused on systemic and structural racism, not the interpersonal manifestations. We do have an internal training on how it manifests internally, both for all different racialized categories. And then I'm also here as a patient advocate and board member for Project Alive. I think I mentioned yesterday that my son was diagnosed with Hunter syndrome. And so I've been working in Latin America, trying to help kids with Hunter syndrome receive access to treatment. And so the difficulties associated with getting access to care within the United States is significant, but when you take it to Central and South America, it gets more complicated and certainly more difficult. Super happy to share the space with you all again.
Well, thank you for the invitation to have us here. And I'd like to start my introduction by doing something that I learned in Brazil, which is describing myself for the visually impaired. I am, I would say, a middle-aged man, Latino man, black hair, black beard, medium stature, and I am wearing a black coat and just clear khaki pants. I am project manager for Latin America for America's Health Foundation. America's Health Foundation is a bridge between the industry and the governments, the local governments, and the goal is to enhance or strengthen public policy across Latin America. My participation here in this panel will be very focused on my experience in clinical trial recruitment for rare diseases. And so I'm very, very excited as well to share this panel with this amazing people, brothers and sisters of the Hispanic community within the US. So thank you for the invitation again.
Thank you all so much. So we want to start with just a few questions to get the conversation started. Beatriz, so we understand, and this is why we're here, that we want to make sure that the families and the patients and the parents of Hispanic families are included in the work and the research and the advocacy of rare disease. In your opinion, what is the best way to involve them in this work?
This is a complex question, and I know that even with our rehearsals and preparation for this, we were trying to figure out how do we narrow the responses to these questions. And as I am very frequently asked this question, the first thing I always say is, we have to do the work. Don't expect that the patients and parents and families and communities should do the work. We constantly reach out, quote unquote, to these communities as opposed to actually immersing ourselves. So it's not it's not reaching out and it's not outreach, it's really integration, it's really engagement. And engagement is the word that I most frequently use when talking to people about this. We heard yesterday about the use of promotoras, and community health workers in general, and the use of other relationships with trusted community organizations. And you notice right now, I have not mentioned at all advertising or marketing, but I quickly want to just jump in on that. Yeah. Okay. No. Okay, so I looked at the latest Pew data, and in terms of, for example, literacy, right? So when we talk about, well, we're making outreach by translating our materials. Well, at this point in time, 38% of Hispanic residents of the United States have not read a book in the last 12 months, any book. And by the way, just so you have it, black is 25% and white is 20%. So reaching out by handing out a Spanish version of this, which I didn't see out on the table. And I don't mean to, please, I don't mean to position this negatively, but just as an example, this is not available in Spanish. Maybe it was, but it wasn't on the table. And even within this, there are citations to websites like Baby's First Test. So I went and looked at Baby's First Test, and to be able to read anything in Spanish, you have to scroll to the very bottom of the home page, and there's a little link to the Spanish version. And then when you get to the Spanish version, the language is unfortunately very complex. So what does that mean? Community health workers are the ones who actually speak the language and the dialect and have the kind of relationships. And those are also the kind of people you can integrate into a team to be able to make sure you're developing the relationships in the cultural context and the linguistic context that makes sense. So that's a small piece of it. But that was one of the most important messages I wanted to make sure I conveyed.
Thank you, I appreciate that. I think maybe we'll move to Vicky, who does this regularly with her hat as a member of our organization, like the SINGAP Research Fund. What kind of initiatives have you guys are doing at the moment to integrate the community, both here in the US and in the rest of Latin America?
Well, thank you so much for this question. And I think that in order for me to explain to you the different initiatives that we have in SINGAP Research Fund for the Hispanic community and engagement, I have to talk from my experience. When I was diagnosed with SINGAP, my daughter was diagnosed with SINGAP 5 years ago, and I went into this devastating news, and I went online, and I couldn't find many resources in my language, even though I spoke some English. Everything was very scientific. It was very hard to understand. On my background is international business, so I didn't have any biology, scientific background, so it was very hard for me to understand, digest, and kind of grasp to that new information that I was getting and what my daughter was going to be like. And then a year later, after my diagnosis, we were invited to be part of a board member of SINGAP Research Fund and also a leader to change that. And that was the beginning of a new start talking about Hispanics in SINGAP Research Fund and finding those Hispanics in Latin America and in the US and what initiatives we could start. And that's when we start with a WhatsApp group that now has 75 members that from Spain, Argentina, Chile, Peru, Dominican Republic, and Colombia, Mexico. We have a monthly meeting with the families by Zoom. We also have bi-monthly webinars that have different topics about mindfulness, about ABA. Some of them, they don't have access to ABA, different topics as brain banks and other ones. And also, we have another initiative that is very important is the scientific conference in Spanish that is coming, the second one is coming on Saturday, where the idea is how to network and build that information and network between the scientists, researchers, clinicians, neurologists, geneticists in the region, so we can all share the knowledge of SINGAP1. And if you don't know something, it's hard to diagnose. So it comes from that base, like how we can give that information out there to that interested stakeholders that are interested to our disease, and how we can increase the diagnosis in our region. So that's very important. And the other one, we have a podcast in Spanish. We have a blog in Spanish from a Mexican family. We have, the podcast is hosted by a Venezuelan that she lives in Texas. So kind of bringing that diversity within our own culture and bringing that communication in a respectful, meaningful way to the whole Hispanic community.
Thank you for that, and I'm so happy that this is working. And so many foundations are looking at you guys and trying to duplicate some of the efforts that you're doing, and I commend you for that. And I just wanted to just move a little bit. So, thank you, Mario Jesser, for that keynote. That was unbelievable. And
thank you.
So we hear this ladies talking, and we know that most of the people working in healthcare want to do a good job. We are, I hope so, we're well-meaning and we're good people. But how come, even though that's what we're doing, the institutions that we are all serving, that these individuals are serving, still continue to produce these outcomes that are inequitable and actually lethal as well?
Yeah, it's a really important question, right? I don't think anybody, healthcare providers, teachers show up thinking about how they're going to disenfranchise or marginalize minoritized communities. And so I think that systems really kind of have their own inertia. I think what ends up happening is that it's easier for us to try and fix the problem at the individual level. It's a lot harder to try and solve the problem from a systemic standpoint. Systems tend to be very entrenched in the way that they work. They function in that manner for a very long time. And so, it's important for us to kind of try and figure out how we can effectively be systems change agents. How do you move your system to try and figure out the problem, solve the problem from a systemic standpoint? And it's a lot harder to do. I think implicit bias was mentioned yesterday. That's a really important piece, right? That people are making decisions at an unconscious level that are hurting the communities that they're trying to serve. That's certainly a part of it. But when you think about implicit bias, who does implicit bias put the onus on or the responsibility on, typically? It's the individual, either the individual doctor or the individual nurse. And so we have to get beyond looking at just how we're showing up as individuals. Certainly that's an important part of it. But if we're saying that the problem is systemic in nature, it's structural in nature, how can we then effectively become systems change agents and really try and figure out, and it's not only is it easier, it's less threatening, right? Because if you can put the onus on the individual and you're trying to fix the individual, that doesn't really put you in a perilous position. If you come to your own institution and you're saying, hey, we have a problem within our institution, the way that we're trying to serve Latinos or African Americans or other marginalized communities, you might run into some problems for sure.
It's more uncomfortable, like they were saying.
Absolutely, absolutely. And you're dealing with the power structure that you're a part of. Somebody said that it's akin to trying to build a plane while flying it. I would say that you can take it a step further. It's like trying to deconstruct the plane while flying it to then try and rebuild it. Because then you recognize that your own well-being, to a certain extent, your own positions within these institutions are also in peril.
Well, thank you. Well, we'll try to do a little bit of that, right?
Yeah.
We're going to shift a little bit and talk about something very important for the community, I believe, which is participation in clinical trials. And Carlos has a lot of experience in this area. And although we all know how important it is, we also know that the underrepresented communities like the Hispanic population is very underrepresented in these clinical trials. Can you talk to us a little bit about that?
Sure. Well, first of all, let's remember that underrepresentation in clinical research is not an issue that affects only Hispanics and Latinos for sure.
Absolutely.
We have heard yesterday and have heard and read a lot of material about underrepresentation. And if we look at data produced by the Lung Cancer Foundation of America, representation of African Americans in their trials is about 17%. Representation of Hispanics and Latinos is between 5 and 7%. Representation of Asian Americans between 2 and 3%. And so we know there's a lot of reasons as to why these numbers are as low as they are, but I'd like to talk about 3, and just going back to what Mario said yesterday, it's not one or the other, but it's one and the other, right? It's many problems combined. So the first one will be barriers in knowledge and trust. Second one, barriers in access. And the third one, protocol design. And when it comes to barriers in knowledge and trust, we have to admit that there's been a lot of advances at a global scale. I mean, the pandemic increased the general knowledge of what a clinical trial is and what is it good for in general. But there's still a lot more to be done, and I would say that is in the key aspect of trust. And when we approach, I would say for those of us that do patient recruitment for clinical trials, when we approach or present a clinical trial to the communities or to the patients, our responsibility is very, it's just very high to make a difference, a very clear difference into what a study is and what an experiment is. Two separate things. And when we talk about this and the Tuskegee Project comes up, the Tuskegee Project, the community, what they want to know is what they want to have is a certainty of what the end goal is. Now, if we think about it, The Tuskegee project had its goals very clearly established. They were just never communicated to the public. I mean, we'll be having a different conversation now if that was the case. But so just to not go very deep into it, knowledge is the key in that sense. And another interesting part about knowledge and trust is just something that doctors hear very often when they present a new treatment to patients, which is, just the fact that that treatment worked for so-and-so doesn't mean that it would work for me. And we heard about this yesterday as well. And they're right. It just doesn't mean that. The only way to debate that is by having the data that supports that discussion. Next thing will be a barrier in access. And here we can incorporate the word representation. And now, a lot can be said, and Beatrice talked about it a little bit, translation and whatnot, but just staying away from that specific point, I would like to talk about representation. Now, representation may have a different meaning for all of us, but the underlying reality is that representation promotes fairness. And we, as a minority, want to make sure that the burdens of the trials, and I'm not talking only about cost, but the burden of the trial is shared evenly and equitably between all the members of society that will benefit from the results of the study. And here's where we go to protocol design, because let's say if some of us have been in touch with protocols, we know that inclusion and exclusion criteria is designed to meet scientific milestones, right? And let's talk about just quickly about an example on a protocol that I run into, which is for Duchenne's muscular dystrophy. A patient had to, one of the requirements was for a patient to be able to withstand a 6-minute consistent walk, right? Now, we have no idea if this patient had to take a 3-hour flight to the research facility, had to, wake up at God only knows what hour to take that 3-hour flight, commute to the research facility, wait for about 30 to 40 minutes for papers to fly back and forth while they're being signed. Forget about eating, that'll be a luxury. But that patient is exhausted. And at that moment, we know that patient is, it's not going to be able to withstand a 6-minute walk, and therefore it's not going to be able to join a study that will potentially increase the quality of his life, right? So going back to a conversation that's been had over and over, it's meet patients where they are. What does that mean for this protocol design? It means that infrastructure for clinical research needs to be built. And I was very happy to hear the Walgreens initiative yesterday, whereas patients will be met where they are located. And this serves two particular purposes. I mean, one of them is increasing the diversity on the clinical research projects, and also making sure that those medical advances are implemented in this communities a lot faster than they would normally be done if this is happening elsewhere. We're hoping to see more of this with the famous DEPICT Act coming along.
And can you tell us just a little bit about this act?
Of course. DEPICT Act is a bill, basically, that it's aimed to increase diversity in clinical research. Basically, what the sponsors are going to be obligated to, I believe, is by December 2023, which is going to be enforced. They're going to be forced to report, it's going to be mandatory to report their clinical trial targets and clinical trial initiatives or strategies. And so they're going to be also, the FDA is going to demand follow-up studies, post-market studies, if these particular targets are not met. And I feel that this is just very important for us as organizations to know, because this is the first, if not the only way in which us as organizations are going to be able to participate in clinical protocol design. And I feel that it's now our responsibility to know how diverse are we, how prepared are we to support that construction, that diversity in clinical research. So I'll leave it at that.
Thank you. There's also another section later on about clinical trials, so we can probably discuss more that at that time. I wanted to talk to Vicky a little bit about this inclusion of these patients in the work that we're doing. And I know that you do this not only in the US, but also outside in Latin America. And I was wondering, how does that contribute to the diversity of your community to be able to reach out to patients all over the world?
I think it's fantastic. Just knowing that there are different patients and different families of different cultures and backgrounds and so, economic and financial and education, that gives a lot of nurtures our community as well, and we understand the difference as well and the needs. And when the patient organization understands the needs and map and how the map is combined and where are the patients located and what their specific needs, we can target those initiatives to those patients, and how we can, even though we are still far from a clinical trial and we still have some treatments in the pipeline, how we can make sure those patients in Argentina, in Chile, in Ecuador, in Colombia are going to be part of that, and how we can help them to be included within the conversation as well. And knowing their needs, and also something that is very important I find from that variety is that you are amazed, even though they are having some different challenges that we might talk later, but it's how we can learn from each other, and how, even though they don't have ABA therapy there, and how they are managing and they are doing it so well, and just how we can learn from each other. So that's very valuable.
Well, now that you mentioned the challenges, I'm sure they're very different, the challenges that we have here as a Hispanic community in the US from the people who are living in those countries. Can you tell us about those challenges, how they're different and how they're the same?
Yeah, well, I could stay here for hours talking about those differences, but definitely I would say, well, we are here worrying about the accessibility and probably the quality of the healthcare, and probably how many hours I'm getting on the ABA, and how we are going to be heard at the IP meeting and the educational point. Those families are dealing with other things, like, do they have anti-seizure medication at place right now? Do they have it or not? Do they have limited health system? Do they have therapies? Are the kids 15 years old going to school because they don't have a system that will take the kids into their school? So there is a lot of challenges there. And over here, we're talking about what is the legal status, how we can build that trust to those families, if they can be part of the natural history study, and how we can make them believe that truly is okay to be in the natural history or in the registries. All those technology barriers that we might face, or the language barriers that we face here in a daily basis. Even myself, when I go to a pediatrician, I cannot sometimes describe my daughter's symptoms clearly because there is a language there that is hard to explain, right? So it's just understanding that it's so hard for those families that live here, that they don't have their village, that they left their families behind. And also, I remember not long ago when I was in a different, being a moderator in a different panel, and a family said, when I had a rare child, I used to have two jobs, one to maintain my family and the other one to send overseas to maintain my family in Guatemala. And now I have a kid with rare disease condition, and now there are two families that are affected economically and financially. So that's another conversation, is how we pretend to have volunteers on the Latino community when they don't have time and they have to do two full-time jobs. And so how we can bring that voice into the table, and how we can assure that that voice is going to be heard, not because of lack of interest, but the lack of opportunity and the lack of the content in their language that they will clearly understand.
That's definitely the challenges that we hear a lot, right? So we work a lot at SHARE with the Society for Rare Diseases, and this is a lot of the challenge that we hear inside of the U.S. And I know Beatriz gets to see a lot more of this, not just in a very small population, but in all the communities that you're working with her kids, and there's a lot of real world challenges that they're facing. What can we do to help? How can we engage with them?
Well, I want to just back up for a second, because there was some wonderful commentary here and some great things that are happening, because engagement and inclusion of all of these issues and addressing everything that you're hearing, a lot of it begins with who's at the strategic planning table. So we have to go all the way to the top in the beginning of the process. And when you talk about things like, flying airplanes when they're not completely built. One of my colleagues at Janssen Pharmaceuticals used to describe it as addressing Hispanic communities as bolting something onto a submarine when it's already underwater, right? So having the ability to back up and start from the strategy development. For example, the wonderful work now that the FDA is doing. When I was on the board of the NHMA, the National Hispanic Medical Association, we were in public hearings in 2010 to begin to address these issues. And so, yes, that's how long it took for us to get to here. And the other thing I wanted to just quickly address is one of the things Vicki brought up, which is, again, once we get tactical, and there isn't someone in the room to begin to address these things from the beginning, any digital design or any community design online you may be thinking you're only addressing the US Hispanic population, but the reality is you're going to get Brasileros and Argentines and all these other people immediately onto whatever forum you put out there, whether it's a Facebook group, whatever. So again, framing the entire communications, outreach / engagement effort, no matter what you're trying to do in a bunch of the work that you're hearing here, begins with having the right people at the table and insisting on being at that table. Because unfortunately, the onus can't be on the parent and the patient. It shouldn't be. It should be on those of us who are designing overall strategy on how to address all of these issues that we're talking about. But that's not what you asked me.
But that is okay. Now you can tell me. So how do we do this? Other than just sitting at the table, I think that's a very important representation, right? So we always agree that that's a very important thing. How else? How do we engage these people and meet them where their issues are?
Well, how you're going to get to that table, right? And how you're going to actually begin to address what the needs are is to, first of all, you have to have data. You can't get anywhere without data. Right. Frankly, you cannot get into the room where the discussions are being held without having demonstrable information, such as the statistics that I mentioned at the beginning. Well, the Pew Hispanic Center didn't exist until some of us came to the table and went to Pew and said, guys, it's time. You can't just have us as a bolt-on, as one panel in the research structure, right? So it begins, again, at the top, and it begins with bringing the kind of information that's necessary. And also, when you start talking about, once you're at the table, you have to be fully representational of a very large and diverse community, right? So you're talking about 23 countries of origin in the US Hispanic community, right? So we have a tendency to believe we know what is needed. And so as I started working on HERD and started trying to understand, okay, what are the issues that any work we're going to do in supporting low-income families, particularly Hispanic families, is, what do you need? Well, okay, I have to get to an infusion center, right? And I'm in rural Texas, and I have to get to that infusion center that might be 50 miles away. Okay, if I can't borrow someone's car or get someone to take me, how am I going to go those 50 miles, right? And so then once I get there, I have to stay overnight because the child's treatment starts in the morning, their infusion of whatever their drug is. And so I have to stay overnight. How am I going to pay for that? And then I have the child care right? For my other kids who are back at home, how am I going to pay for that? So again, trial design, right? Taking into account what in the industry is often called HECOR. Anyway, let's call it the day-to-day realities behind. I'm not going to try to use pharma lingo. Right? Stay away from that. But really understanding what are those day-to-day issues. So in part of my work, I go to community centers and I sit down and listen. And what are the things that are keeping you from being able to access organizations that can help you? Opportunities for research, involvement in research, opportunities to find digital platforms where I can interact and share. And at 2 o'clock in the morning when my child is having a seizure, who can I talk to, right? So we have to be humble enough, right? We've many times yesterday and today heard about walking into the room with humility, leading with listening, all of these concepts because we think we know.
I know that, so yesterday we were listening to this gentleman, Italo, I think is his name, that he talked about the barber shops.
Yes, yes.
And we were joking, like, what is our barber shop like?
Our equivalent to the barbershop, yeah.
What is our Hispanic? Where do we go that we feel like that? And we're like, is it the hairstylist? No, women. So you're like, is it the taqueria?
Somebody talked about the taquerias yesterday.
Yeah,
I think it was. And we agree. I mean, for us Mexicans, it is the taquerias, but may not be for Venezuelans or Colombians. It's very many different spaces.
So one of the things I'm finding is actually sometimes it's the markets where they go and buy things, right? So I have Los Jalicenses up here in Redondo Beach, where literally I'll go in there sometimes and I'll just, as I'm standing in line to buy something, I'll hear people talk and I'll just ask them 1 or 2 questions. It's where the community gathers.
I think that brings back also the idea that we are so differently culturally, right? So it's not like we can just say, oh, we just go to this place to talk and this is where we feel comfortable. No, every country, every culture, we have, we will go to the arepera when you go to the taqueria.
Right.
And
or the domino game.
Or the domino, or you go to the park and you see the gentleman playing dominoes, right? So even in that special particular comment of like, oh yeah, let's go and bring the promotoras, where do we bring them? Do we, so the community centers are a good place, but even that.
Church is also a big one.
So faith-based institutions, but even that, I find that the community is pretty diverse in that sense as well. So yeah, it becomes a challenge. But something that you mentioned, and I have Mario talk to us about it more, it's about we cannot make the population be responsible to belong in. And that brings us to the chance of how do we move that responsibility, that blame from the patients into the institution. So Mario, I know that this is something that you're passionate about, moving the blame away from the patients.
Yeah, I think the article that I shared from the NIH yesterday that talked about how our interventions are really just targeting the individual, or traditionally have been targeting the individual and not the systems themselves, really speaks to that. It's tough. I think, when you have those, when I was trying to construct the talk, I was like, do I want to say that I want to dismantle structural inequity, or do I want to say that I want to dismantle racism and white supremacy? And it was like, how hard do I want to, hit folks to a certain extent? Because I think that, unless you're 400 years old and you found the fountain of youth, nobody in these rooms constructed these things. But the reality of it is that when they were constructed with only one racialized group in mind. And so the fact that our white brothers and sisters are having the best outcomes in these systems and institutions doesn't speak to systems that are broken, right? It speaks to systems that are working exactly as they were intended to work from the beginning. And so we have to figure out, again, how do we disrupt these systems in a very intelligent and strategic way and create the critical mass even within those institutions to try and really kind of not necessarily lay the blame, but the responsibility on the institution itself. We keep talking about, well, building trust within the community or educating the community in order to gain their trust. Oftentimes I feel like that, again, is kind of saying like, oh, well, the community doesn't know what's going on. No, they're very well educated, and that's the reason why they don't trust you. So I think that's part of it as well. And then I often think also about, I don't know who it was that asked the question about where the money is going. That's such an important question. And I think about a quote from Dr. King that budgets are a moral document. So all of the millions of dollars that are being spent with respect to clinical trials, drug research, et cetera, is that money getting into the community? And if that money were getting into the community, would that also help build trust, right? Because now you're not only saying, hey, we have this program, we need your help with implementing it, right? And we're also going to kind of employ you in this change. I think we also have to be careful because, diversity is certainly significant and that needs to be a piece of it. But we can't confuse diversity with equity because that's not going to get us there. I think the example that I often use is that, and the Black Lives Matter movement was born under a black president with a black attorney general. So the most powerful police chief, if you will, was black, and the president of the country was black, and this is when the movement was born. And so we have to be careful not to confuse diversity with equity. And what I will say is that oftentimes we come into the spaces and people want solutions, right? They want to figure out, how do we solve these problems? I think the reality of it is that the problems are so incredibly complex, entrenched for hundreds of years. And I think that a huge part of the issue is that I don't know that we understand the racial and ethnic divide in this country enough to really figure out what the solutions are. I was talking to somebody yesterday, and I was thinking about a quote that I love from Albert Einstein, where people are like, you know what, you're so intelligent, the way that you approach problems is so different than what other people, and he says, no, it's not about my intelligence. It's not about my intelligence. He said, it's how I typically approach a problem. And what he said was this: if you give me an hour to solve a problem, I'm going to spend 55 minutes trying to understand the problem. And then I'll spend 5 minutes trying to solve it. We do the opposite. We're confronted with a problem, we don't really understand it, or the depths or the complexities of it, and immediately we want to jump to solutions. And then we end up coming up with gimmicky solutions that really don't work and end up, in the end, I think, laying the responsibility or the blame on individuals or individual communities. But again, it's a lot harder to move systems and institutions. And I'm not at all suggesting that you run up, you charge up the corporate hill on your social justice horse and, talk to your leaders and say, hey, we have to dismantle racism and white supremacy. This institution is a part of the problem, because you're probably going to get cut off at the knees, right? And we certainly don't need that. I think it's a matter of really creating a critical mass. And what it means is we have to get better with respect to organizing. At the Racial Equity Institute, we have a lot of REI-isms. One of my favorite ones is that an organized lie is more powerful than a disorganized truth. And the problem is that the lie that we're trying to confront is extremely well organized, is our truth. And so that's the charge, right? I will say this, a shameless plug. REI has received a grant from the Chan Zuckerberg Initiative to bring in patient advocacy groups, umbrella organizations. I'm hoping to have the RDDC, the Black Women's Health Imperative, Global Genes, NORD, and any other organizations that want to, this is not about checking a box, but really to sit down and have very difficult discussions so that we can bring a race analysis to the problem. I understand that there are other forms of oppression, but I think racism is kind of the glue that holds all of this together. So that if you're dealing with, sexism or ableism, and you happen to be a person of color, it has a compounding effect. And so, over the course of the next couple of years, we're going to be bringing these interested stakeholders to the table to really try and figure out how we can be systems change agents. And look at this from a structural or systemic standpoint and not just continuously deal with it at an individual level.
Thank you and congratulations on that grant, by the way.
Yeah, thank you so much. I appreciate it.
Well, in the last, we only have maybe a minute per person, and maybe in the last minute, you can give us because the idea today was not just to talk about our problems, but to give us some tools on how to improve the situation. Vicky, in a minute or so, can you give us some things that the foundations and organizations can do to make this, to make the inclusion and better for our Hispanic society, community?
Yeah, I think one of the important things is are we patient organizations ready for representation? Are we ready to have some change inside for bringing Latino into a board or representing as a leadership? Because I think DEI is more than a checklist. I think it's a transformation, and it requires commitment. It requires time. It requires understanding the community as diverse as it is, and also that is worth it. That is worth that effort. That is worth that time, and it will definitely pay off bringing that community and different knowledge from that, because that's where the trust begin, building that community and how we can transform our reality also as a community.
Thank you. Beatriz?
Well, being an engineer who came into marketing, one of the things that I've always been determined to do is formal listening as well. And so I'm a big believer of the
Believer.
Creyente.
Creyente.
Creyente, thank you. I am Spanglish today, sorry.
¿Por qué no?
I'm sorry?
¿Por qué no?
¿Por qué no?
Well, because it's not inclusive. There you go. Formal research, and I mean not just necessarily qualitative focus groups, but also quantitative surveys, integrated marketing strategy. And I'm talking marketing strategy, and I know it sounds like we're not going to necessarily be able in that context to address some of these larger issues, but that's not true. We will hear, and we will hear from people. You'd be astounded how desperate people, meaning parents of people with rare diseases as well as people with rare diseases, how desperately they want to be heard. And I recently ran a focus group, or one of the people who was going to be eliminated from recruitment because her daughter was hospitalized, which when you have CF, you're in the hospital about 3 months a year on average. And her daughter was literally in the hospital bed, but she insisted on joining the focus group from her daughter's hospital room. So they want to be heard. Give them the context, give them the format, and meaning them, the parents and patients, but also integrate them into the actual design of the research, which a lot of organizations do not think to do. They hire a formal research firm and do not necessarily have any of the target population in that research design, right? Again, so it's who's in the room. Right. So I'm sorry I went past a minute, but
I want to just hear Carlos something to say about that.
So I noticed that I skipped to describe what DEPICT is. Many of you may know, but it's the Diverse and Equitable Participation in Clinical Trials Act. That's what it is. And so I come from, I've heard Beatriz is describing what her background is, and what brought me into the medical world is my experience on nonprofit management. I did a lot of projects in Latin America for other things, education, economic development and whatnot. And when I joined organizations that were patient organizations, I noticed that the complexity of running the organization, it's parallel and it's very challenging with the complexity of taking care of the patients and moving forward with whatever purposes they had. And so the only thing that I would say for organizations is to question, internally, to question ourselves and just see if we are not checking the box. Are we checking the box as well for diversity? I mean, when we're employing new collaborators and whatnot, are we just checking the box because legally we are forced to do so? That's, I think, what we need to do in order to prepare and to participate a lot better on this clinical trial design that we're talking about.
Well, thank you so much. And I'm sure that all of us are here, and you can find us on LinkedIn, social media, wherever it is. If you have any questions about how include the Hispanic community in your foundation, in your research, please reach out to us. We'll be happy to share any of the tools that we have developed in our work. With that said, we have time for one question, I think I was told. So if anybody, apparently just one. Or if they're quick, maybe we can put in two.
Can I just say one thing before we get that question? There is this idea that when we're talking about equity, that this is a conversation solely about inequitable results for indigenous folks, African, minoritized groups, right? That what we need is allyship on the part of our white counterparts. This is not, when you compare collective outcomes for our white brothers and sisters and the people of color, yes, they're having the best outcomes, but compare them to their European counterparts. They're terrible. They're absolutely terrible. And the reality of it is all of this inequity is killing us all. And so, for our white brothers and sisters, is not allyship. We need co-conspirators. You need to understand that you also have a dog in this fight. Mm-hmm. That as much as it's hurting communities of color, it is also hurting you.
Amen.
And so insofar as a main takeaway, this is not about blaming or shaming anybody. We need everybody at the table. Everyone at the table, if we're going to really achieve equity.
And I would just jump in and include, please, just really question your ableism. Remember that we're talking intersectionality as another major component.
Go ahead.
Great discussion. Thank you. One quick question. I have heard two sides of perspective on whether to include this race ethnicity question in many of the forms, whether it's related to health or otherwise. Why do they need to know my race if they have to do X or Y, right? And then without that, we obviously cannot do certain activities that's supposed to happen. So where can you kind of help put perspective on where systemic racism stands with respect to asking these questions about race and ethnicity or not, where it makes sense, where it does not?
That's a super important question. If I could just jump in, I think that you can't remove the tool that we use to measure the disparity until we get rid of the disparity. This idea that we live in a colorblind society, it makes us feel good, but it's nonsense. And so, hopefully we'll get to a point where the social construction of race will not matter. It matters. It absolutely matters still, because we're trying to deal with those disparities. And again, a problem within the rare disease community is that we're not marking that disparity. And so again, it'd be great to get to a point where we no longer use this racial construction to divide us up, but we need that until we get rid of that disparity, unfortunately.
Agreed.
It's a great question.
I think we have maybe one more question.
No, Rachel's
No, Rachel's nope. Well, thank you so much. It was a pleasure talking to you guys, and thank you for listening.